everyone. Special greetings to all participants in my Parkinson's disease therapy group. My name is Sinn-Chye. I am the full-time Parkinson's disease caregiver to my wife May, who has been a patient of the Parkinson's disease since 2017. In this short video, I want to share with you the things that I have learned out of necessity since becoming a PD caregiver to May. I admit that ever since I started playing this caregiving role earnestly, it has been a journey of discovery and learning for me on things that I need to know and do. Even now, I consider myself a novice in playing this role simply because there is still very much more for me to learn. My journey began when May and I attended a PD-related meeting in Penang in October 2023 at the Penang Harmony Center. This meeting was co-hosted by the Penang Parkinson's Rehabilitation Association together with other participating agencies. Like some of you, at this meeting, May and I volunteered to participate in UKM's PD Caregiver program, which is still ongoing as I speak. We were subsequently selected and placed in one of the so-called usual therapy groups, UTG for short, that the program has set up. As participating UTG members, we were given an assignment to do. A specially prepared Parkinson Caregiver logbook, as shown on your screen now, complete with instructions, were mailed to us by the team coordinator, Ms. Shamila of UKM, in early February 2024. By the way, I would like to add at this juncture that several evaluation sessions aimed at assessing the physical abilities of PD patients, like my wife May, are also being conducted by qualified personnel in the course of this assignment. Now, a few words about the aims of the UTG assignment. As shown, the aims are to track and record on a daily basis the progressive development of the PD patient's physical and mental well-being, with reference to the medicines ingested, food consumed, active and passive exercises done, speech therapy, and stress management-related psychotherapy exercises carried out. As a participating PD caregiver, I was instructed to input relevant information in the given logbook based on what is done every day of the week by May, over a period of 12 weeks. The data requested are what I have just mentioned earlier, namely the medicines ingested, food consumed, active physical and passive exercises done, speech or vocal exercises, psycho-relaxation exercises performed. This exercise began on the 12th of February 2024 and ended on the 5th of May 2024. Perhaps at this point, I should tell you about May's daily struggles with PD. Presently, May's daily struggles include sudden blood pressure drop, giving her dizzy spells or even fainting, shortness of breath, which affects the way she speaks, dyskinesia, resulting in poor body balance, accidental tripping and falling, coughing, choking, swallowing difficulty while eating, constipation and stomach bloating, frequent urination and incontinence, and body weight loss. On your screen now is the medication that May's panel of doctors have prescribed for her to take. And these are the Madopa tablets, Entacapone HEC, also called Comtan tablets, Madopa HPS capsules, Selegiline tablets to treat muscle movement disorders, Cerovin tablets, a blood thinner, and lactulose oral solution, a mild laxative to treat constipation. These medicines, with the doctor's recommended dosages that May takes at this stage of her PD progression, are as shown here. The top 4 are specifically relevant to PD treatment. From our experience, the dosage of one particular medicine, namely Madopa, must be carefully adjusted with regard to its so-called wearing off time. Off time is characterized by the re-emergence of PD symptoms as the effect of the medicine diminishes near the end of the dose interval. This lasts usually 2 to 3 hours after a dose. For May, this is particularly a troublesome issue, hence a challenge that we have to resolve as days go by. I have labeled it as the Madopa factor. Of course, there are other factors that play important roles in this context, but time constraint does not permit me to talk about them in this presentation. Instead, I will focus on talking only about how May and I address the Madopa factor challenge in May's case. In order to do so, I had to first understand the conditions under which Madopa is to be ingested. I then worked out a 24-hour personalized mealtime and medication scheduling chart for May, taking into consideration 2 other closely related factors. It is a tough balancing act that entails careful time management. 3 factors come into play here, namely medicine dosage and dosing frequency, food type, and the preferred mealtime. The possible interactions between these 3 factors have to be clearly sorted out and strategically pinned on the timeline, readjusted if necessary, before a workable mealtime and Madopa medication schedule can be finalized. By comparison, time setting for the other medicines that May takes daily is less problematic and can be easily set. On your screen now is a diagram that I have drawn to explain the fundamental connection between Madopa dosing and food intake. Clear instructions on how best to take Madopa are available. In general, people with Parkinson's disease are advised to separate Madopa from food intake. They should take their medication doses either 30 minutes before or 1 to 2 hours after a meal. Such conditions are more easily said than fulfilled for many reasons, mostly caused by event interruptions happening on a particular day. I am sure that some of you have encountered such situations. Questions like, what Madopa dosages are you taking? How many doses per day? And what is your meal time going to be? Are very important in this regard. The main aim of doing this is to try to reduce the Madopa off-time symptoms as mentioned earlier. The outcome of our deliberations and planning yielded a personalized chart that is applicable to May. It displays her mealtime and medication schedule covering one whole day. Let me now zoom in to show you the relevant details. With daily breakfast set to begin at 8 a.m., May takes her first Madopa dose together with Comtan at 7 a.m. each morning. Then at 10 a.m., she takes her second dose of Madopa together with Selagiline. Lunch is set to begin at 12 noon. May's third dose of Madopa, together with Selagiline, are taken after lunch at 1:30 p.m. Coffee break comes on at around 3:30 p.m. or so. Her fourth Madopa dose, together with Comtan, are taken at 4:30 p.m. May takes her fifth dose of Madopa at 7:30 p.m. in the evening. And before going to bed at 10 p.m., she takes the Madopa HBS capsule instead. Madopa HPS is the slow-release form of the regular Madopa. No medicine is taken after that until the next morning. So there you have it, the personalized medication chart for May. Does it work 100%? Well, even with the present arrangement, May still experiences Madopa off time at least once a day, sometimes twice a day. But her off time are generally more tolerable now, so she told me. As parting remarks, I wish to say the following. I think I am a better informed person now with regard to PD caregiving. Caregiving is a 24/7 job that comes with heavy responsibilities, some of which I have yet to encounter. Clearly, there is still much to be learned and carried out. I have to stay in front of the learning curve in order to perform well as the PD caregiver to May. As May's PD progression pattern unfolds, I hope to get a clearer picture with regards to things that I have to do or preventive measures that I have to undertake. In this regard, I pray that both of us will remain physically fit and emotionally steady enough to cope with the ongoing as well as future emerging challenges and demands. In concluding, I wish to take this opportunity to thank UKM and in particular the coordinator as well as members of the UTG team for the privilege to interact as a volunteer PD caregiver in this assignment. I now look forward to receiving any interim report and further instructions or advice in due course. Thank you so much for your attention. Have a nice day.